Now, just a reminder that we are invasively ventilating our patients. So that means we can cause a great deal of harm if we don't initiate the correct settings. Those settings include, but are not limited to, the patient's mode, the frequency, tidal volume, PEEP, and FiO2. Now, again, the initial settings for our patients are to decrease or eliminate the patient's work of breathing. So you need to know what your patient's ideal body weight is in order for you to set the correct parameter for the tidal volume, for example. So our initial setting is also going to be placed on the patient to achieve an acceptable patient comfort. And again, we do not want to cause any harm to our patients. So it's very important to know what the initial settings are for each individual patient. Some settings will be prescribed for you, and we'll talk about each one of those here shortly, but I do want you to know that there are some settings that will not be prescribed for you, and those include settings like your flow trigger and your inspiratory time. Now, one of the most important things to know is that your settings, your prescribed settings, may not always be correct. So you always want to check your prescribed settings to be just to be safe. And one of the more important ones to check is that tidal volume. Okay. When you calculate your patient's ideal body weight, you're determining what your patient's tidal volume range will be, right? So not always will the physician know what that range is. Sometimes they may order a volume that's too high for the patient. And you want to prevent harming your patient, so a way to do that is by double checking the prescribed tidal volume. Now, you don't want to find yourself overventilating your patient or even underventilating them. Typically, your physicians will prescribe the following settings. Those include the mode of ventilation, the respiratory rate, also known as the frequency, the tidal volume or the pressure, depending on which mode the patient is set on, the FiO2, and your peak end expiratory pressure, your PEEP. Each facility is different, so there are many protocols in managing a ventilator along with the initial settings, but there may be times where you'll have an order that reads respiratory care to manage the patient by the ARDS.net protocol. And what you'll simply do is follow this website, adjust your patient's settings according to that protocol. So if your blood gas read this, you're going to follow the steps according to that blood gas that your patient you reported for that patient. Excuse me. So if your physician orders this, for example, it saves you the trouble of having to call your physician to adjust any settings once you do obtain that blood gas. Let's say your patient's CO2 level was high, and this is an ARDS patient. All you do is simply follow the protocol. But we know that we would adjust what our tidal volume or rate, or maybe both, depending on how critical the patient is. So what you'll do is simply follow this ARDS.net protocol without having to call your physician and get that order to change settings for your patient. So it does save you that step of having a call to get an order to change a tidal volume or any type of setting. So it also helps your guide your decision making. So although I know you are a great therapist, you're all going to be wonderful. It does help guide that decision making just to make sure that, okay, this is what I think we're going to do, but let's double check by visiting this website. And also, the main thing here is you have that window to kind of adjust your settings without having to call your physician. The settings that are not prescribed for you include the trigger sensitivity, which is what makes your machine turn on? Is it the pressure or is it flow that's turning on your ventilator? Now, depending on the ventilator that you're using, you'll set the inspiratory flow on some ventilators, some you won't. Now, the Draeger has a default autoflow application. Some vents you'll need to dial in what you want that inspiratory flow to be. You're also going to be responsible for setting the correct inspiratory to expiratory ratio, or also known as the I to E ratio. Other settings that are not going to be prescribed for you include the I time. Now you're going to adjust this as necessary. Know that the I time is not available in all modes. This is available in the pressure control mode of ventilation. Okay, so you're going to adjust the I time in that mode as necessary. Other alarms that are not going to be prescribed for you are, I said other alarms, I'm sorry, other settings include the alarms and the alarm limits. Now, those include your high and low peak pressure alarms, your high and low tidal volumes, high and low frequency, so on and so forth. That includes your apnea alarm as well. Now, the backup ventilation is going to be set once you set up all your alarms. Okay, once you have set up all your alarms, you will have set a backup mode of ventilation. So, for instance, if you were weaning a patient that was previously on an SIMV mode of ventilation with the rate of 10, tidal volume of 500, PEEP of 5, 30% FiO2, and you change the mode over to a CPAP mode for the patient to do all the work of breathing. Basically, you're just assisting the patient at the minimum level. Now, if you had all your alarms set and you have the patient on a CPAP mode and they went apneic for more than 20 seconds, then that ventilator is going to turn back into the previous setting. It's going to jump in and work for the patient, do the breathing for the patient at a rate of 10, a tidal volume of 500, PEEP of 5, 30%. It's going to kick in and take over. That is the backup ventilation. Now you may see that there's a little bit of a difference between each ventilator, so keep that in mind. Humidification. You're going to determine as a RT which humidification device you're going to use. Is it going to be a short-term patient or long-term patient? So of course, if it's a short-term patient on ventilatory support, we're going to decide on using an HME, right? Whereas if it was a long-term patient that, for example, a trauma patient, we would probably use a heated humidifier. When we talk about the mode of ventilation, we're actually talking about the type of breath that the patient is going to be receiving along with the pattern of that breath. Now, in this illustration, we have an SIMV mode with pressure support, and it is a volume targeted mode of ventilation. We have three different scalars. We have a pressure time scalar, volume time scalar, and a flow time scalar. Now let's look at the first breath. We know we are in a volume targeted mode of ventilation, so that first breath in the green is a volume targeted, not triggered by the patient breath, and it is a time cycled breath. Now I want you to take a look at your pressure time scalar. You'll notice that this patient took a spontaneous breath or had a spontaneous effort to trigger the machine to deliver a breath. It is a patient-triggered pressure support breath. So this means that the patient's SIMV mode has pressure support added as well. It is a patient-triggered pressure support breath. Now again, when we talk about the mode of ventilation, we're actually talking about the type of breath that the patient is going to be receiving along with the pattern of that breath. When we talk about the breath type, we're talking about whether the breath was a mandatory breath, meaning that the machine gave the breath, or if it was a spontaneous breath, the patient took the breath, or an assisted breath, meaning that the patient started the breath and the machine assisted or helped with that breath. Now, also, what type of variable was targeted? We have to look at whether it was a volume control or a pressure control variable. The second factor you want to consider in your mode is the timing of your breath. Was it a continuous mandatory ventilation, which is also known as a CMV, or an intermittent mandatory ventilation, or more specifically, a synchronized intermittent mandatory ventilation? Or was it a spontaneous ventilation? And we're going to talk about each one of these in more detail in the next lecture. All right, in Unit 3, we are going to be covering in great detail waveforms and all that comes with it. But before we get to that point, we are going to run into many graphics and we have to have some sense of understanding of what we're looking at, right? So I've included this slide just to refresh your memory on where the Y and the X axis lies and what variables are plotted against those. So as you can see in this illustration, the variable plotted on the Y axis is volume, and the variable plotted on the X axis you have time. Okay, so really and truly up to this point you've seen three different types of scalars. You've seen the volume time scalar, pressure time scalar, and the flow time scalar. All right, don't read the description on the left side here. Look at your volume time scalar here that's illustrated, and I want you to try to interpret or read what this is telling us. Okay, so really this is just a picture of what's going on your machine. Okay, so you have settings set for your patient. I want you to just read what you can interpret from this picture alone. Okay, so I'm going to give you a few moments to interpret that. What can you gather from this scalar? So first off, again, we have a variable on both the Y and the X axis, right? We know we determined the X axis is going to have time and the Y axis will have volume, pressure, or flow plotted against that axis, okay? In this scalar, we have a volume time scalar. So we have volume on the y-axis and time on the x-axis. Now, what you should have interpreted by looking at this picture alone is that you did deliver a little bit more than 500 milliliters or cc's of tidal volume, and that the respiratory cycle lasted 2 seconds, okay? When interpreting waveforms, you're typically going to have at least two waveforms. These do represent the same time frame. So for example, we have a volume and pressure time scalar here on the right that represents the same breath. The respiratory cycle was 2 seconds long and we delivered a little over 500 milliliters of volume. And the peak inspiratory pressure to deliver that breath was about a little bit less than 15 centimeters of water pressure. So again, typically you're going to have two waveforms that represent the same time frame. So you've made it through the introduction of modes of ventilation. So we're going to go ahead and jump into the next two lectures. We're going to start off with volume control.